Our objectives for today are to explain the epidemiology of opioid overdose in Tennessee, describe the Naloxone Rescue Act of Tennessee and the associated Good Samaritan protection, examine risk factors associated with opioid overdose, and we're going to demonstrate how to use intranasal or intermuscular naloxone in an overdose situation. So let's begin by talking about the epidemiology of opioid consumption in the United States and in Tennessee. The United States consumes twice as many opioids per capita than the next closest nation. And then Tennessee is the number 3 state and the number one, oops, sorry guys, and the number 1 country, and Alabama is number 1, and Mississippi is a point and a half behind Tennessee in 4th place. So East Tennessee is number 1 in the state for the highest rates of opioid consumption. We'll see. So in 2019, Tennessee was 11th in the nation for opioid-related overdose deaths, and this is up from 15th in 2017 and up from 13th in 2018. As a state, we averaged 27.5 deaths per 100,000 total population, and this value is increased from 24.5 deaths per 100,000 in 2016, and again, we're at the 27.5. With the overdose deaths on the rise, there is significant work to be done to lower this death rate in our area. So in 2017 to 2018, the highest rates of opioid overdose deaths occur in the northeastern part of Tennessee. And as you can see, the blue areas have decreased in northeastern Tennessee, which may be because of awareness raised in our region from, for example, like the RAM clinics and trainings like these. But while Washington County went down the 10% or more in 2017 to 2018, Sullivan County went up 10% or more during this time, still putting Northeast Tennessee in the highest opioid deaths.
So as Madison mentioned, while we continue to provide training and education across the state of Tennessee, overall, you can see that the overdose deaths do continue to rise. So in 2016, that's the gray bar to your right, 1,631 people died from an overdose death. In 2018, that number increased to 1,818. And so the increasing death rate really emphasizes the need for widespread naloxone overdose education and distribution across the state. The Naloxone Rescue Act in Tennessee went into effect on July 1st, 2014, and it allows a licensed healthcare practitioner to prescribe naloxone to a person at risk of having an opioid-related overdose or a family member or a friend of the at-risk individual. It does require training and administration of naloxone prior to the drug being prescribed. The person trained is protected under the Good Samaritan law, and this is a law that protects those who are acting in good faith and acting in specific circumstances like an emergency situation, such as an overdose. So the person providing assistance, therefore, cannot be sued for trying to help in an emergency situation. The law was created to encourage bystanders to help, or in other terms, it's immunity from civil prosecution for both prescribing practitioner and the individual administering the naloxone. So now we have a short video for you to watch, and I really want you to pay close attention to this video and what's going on, and we'll have a brief discussion afterwards. So what did you all notice as the video progressed? I'm thinking specifically, how did the bird's appearance and behavior change? And you can just shout it out or throw it in the chat, whatever's easier. So Susie says tired. Yeah, so definitely over time, the bird got more tired. What else? Did you notice anything that changed about him? Worn out and hopeless. And then Katie said that the bird gained weight, and Jonathan said anxious. And Dawn said dependent. Seemed to develop tolerance, and it stopped making him feel good. So yeah, so you guys hit on some big points there with the tolerance and the stop making him feel good. That might be sort of a dependence, right? Let's see. And then Steve says the good feeling of flying was never as good as the first time. Right. So over time, he wasn't getting as high with each subsequent use. So that leads us into some terminology that we use when we think of substance use disorders. And so our first word is dependence, and you all touched on this. And this occurs when the body adjusts its normal functioning around regular opioid or other drug use. It's a physical need of the body to function properly, and unpleasant physical symptoms occur when the medication is stopped. The next word on our list is tolerance, and you all touched on this as well. And this occurs when a person using opioids or other drugs begins to experience a reduced response to the medication, requiring more opioids or other drugs to experience that same effect. So that's him not getting as high with each use. That would be a tolerance. The next word is withdrawal. And that's the combination of physical and mental effects that a person experiences after they stop using or reduce their intake of substances, such as prescription or recreational drugs. And symptoms include vomiting and diarrhea, and it's often described as one of the worst feelings imaginable. So many people that have substance use disorders often use in order to avoid this feeling. The next word we have is addiction, and this word is one that we want to be really careful with because, as we mentioned, we really want to reduce the stigma around substance use disorders. And so this word can often be very stigmatizing. And so we do prefer the term substance use disorder instead. And so this often occurs as a person has developed drug or opioid tolerance and dependence, making it physically challenging to stop drug use and increasing the risk of withdrawal. And then finally, our last word there is stigma. And so this is a set of negative beliefs that a group or society holds about a topic or a group of people. And those suffering from substance use disorders are often stigmatized, even in healthcare settings. So we're really working to minimize the stigma placed on these patients. And I think I saw something in the chat, so let's see. So Sierra said, my clients who have had COVID, when it's at its worst, said it's very similar to what they experience in withdrawals. And so I've actually had COVID, so I can certainly understand that it's not a feeling, it's not a pleasant feeling at all. So yeah, it's definitely something that these patients are wanting to avoid.
Okay, so what are some commonly abused opioids that you guys can think of? You guys can throw them in the chat or say them out loud if you want. Okay, I'll just move on to some that we've got. Oh, is everyone in the chat?
Yeah, Katie said Percocet.
Yes, that is one. So here are some common opioids. You can see on the one side, we've got their trade name or their generic name, and then we've got the street names on the other side. And so in order to understand the scope of the problem with opioid medications, we must first be aware of what opioids are. and they are either naturally derived or synthetically derived drugs that originate from the opium poppy. And so, as you can see, it's good to know some of the street names in case you come across an overdose and they may not know what the generic or the trade name is, and they might like say that they're just on junk or dollies, and you would know that they have overdosed on opioid, and that's in fact methadone.
So this is something else that you can either just shout out or throw in the chat. What's the difference between someone who's high versus someone who's overdosed? Let's start with someone who's high. Can someone describe how they would look or speak or act? And I'll tell you, there's one key difference between being high and overdose. So let's see if you can pick up on it. Talk fast and move a lot. So Felicia, that's actually likely to be the opposite. So when they're high, it's really going to depress their system. And so they may have like slowed or slurred speech. So yeah, like Susie said, spaced out, definitely. Now, can someone tell me what someone who's overdosed would look like? Unconscious, exactly. So the big difference is that they're unresponsive. Yep, Sandy, you're right. So an important part of layperson education is recognition of an opioid overdose. Symptoms of being high on opioids include relaxed muscles, impaired speech, drowsiness, responsive to shouting, a sternal rub or an earlobe pinching, something that would just get the person's attention. And they would have a normal heart rate and also a normal skin tone. Someone who's overdosed, on the other hand, will not be responsive. And you guys picked up on this. They'll often have pale, clammy skin, and their breathing is infrequent or absent. Sometimes they'll have this phenomenon called a death rattle. And so oftentimes, because it sounds very similar to snoring, people will assume that they're breathing, but this is actually the step right before the respiratory system is shutting down. And they will also have slow to an absent heart rate, and they may appear blue around the lips and fingertips due to the lack of oxygenation. So like we said, the key difference is that in a state of overdose, the person is unresponsive to any kind of stimuli. So the purple part of this diagram is what we call an opioid receptor. And the receptor shown is in our brain, but they can be found all over our body, especially in other major organs such as our heart and our lungs. So the green figure is an opioid such as oxycodone or heroin. And that opioid fits exactly into the receptor. And so when we have too many of these opioids fitting into the receptors, it causes an overdose to occur. And because they're also found in the lungs, breathing will slow and eventually stop if the overdose is not reversed.
So, what are some common risk factors for an opioid overdose that you guys can think of?
So Caroline says poverty. Certainly. History of trauma.
Okay, yeah, so like some mental illnesses.
Increasing tolerance. Chronic pain. Yeah, you guys are hitting on some big ones.
Yeah, so those are some good ones. So one common risk factor it kind of hits on with the tolerance is abstinence or not taking the drug for a while. And this can be seen in people who are incarcerated or have maybe tried to complete a detox or something, and they believe that they can use more of the same amount of drug that they did before they were incarcerated or tried to do a detox or anything like that. So people who have been abstinent from taking drugs are at risk because they can believe they can take that same amount that they did before they quit. Some other common risk factors for someone is those who have previously overdosed, if they do have that history of addiction, if there is a change in the dose or purity of the drug, Mixing substances like benzos or alcohol, because those can cause any further depression. And then any chronic medical illness can put somebody at risk because they may not be able to metabolize the drug as well, or simply using alone, because if they're alone and overdose, there's no one there to help them. Some other common risk factors are if they are changing from an immediate release to a long-acting opioid, being prescribed higher than 50 morphine milligram equivalents per day, having a comorbid mental illness such as depression, or getting prescriptions from multiple pharmacies or prescribers, and also receiving a methadone prescription. Methadone is very long acting and has unusual kinetic factors, and drug interactions can increase these. So the key point is we need prescribers and pharmacists should evaluate each patient prescribed for opioids for their risk factors of an overdose. So there are many common myths expressed on the street or in certain regions of the state on how an overdose can be reversed. And so there are many things that we don't want you to do because we've actually heard of people doing these. So we don't want you to put them in a bath, especially like a cold bath, because one, they could drown, or also if it's cold, it can further depress their respiratory system. We also do not want to induce vomiting or give them something to drink because they could choke. We do not want to put the person again in that ice bath or anything that would cool them down. We do not want to stimulate the person in any way that can cause them harm, like slapping, kicking, or punching them, because these aggressive actions can cause long-term physical damage. And we definitely don't want to inject them with any foreign substances like salt water or milk. We actually have heard of people thinking that they can inject milk into them and it will help with their overdose. This can lead to severe infections or even heart virus or transmissions or abscesses. So the key
Sierra
point we
also
want you
said, oh, I'm sorry.
oh, sorry.
Sierra also said that don't make them drink milk. That's also a myth. And so yes, Sierra, we've heard that one as well. Which is funny because usually you say that and people are like, "What? Milk?" But yeah, we get that quite often. So yeah, definitely avoid drinking or injecting milk. Yeah, it was a wives' tale. Yeah, I think it's pretty popular in our region. So it's definitely something that we want to avoid and make sure that others know to avoid it as well.
Definitely. So the key point we just wanted to make for you guys here is that naloxone is the only effective response to an opioid overdose emergency.
Okay, so from the illustration, we can see that naloxone has a greater affinity for the receptor than the opioids. So reversal with naloxone may occur immediately within 30 to 45 seconds after the first dose, or depending on the amount of opioids, it may take several minutes or even several doses to work. So it's important to realize that despite the greater affinity for these receptors, naloxone has a short half-life of about 30 to 45 minutes, putting patients at a risk for going back into an overdose state. Therefore, naloxone is a temporary solution and it provides patients the time to receive further medical assistance. And so there's many myths about naloxone administration by laypersons. And so it's important to realize that these are just myths. So in order for a person to become addicted to the substance or to a substance, the dopamine pathway must be stimulated. Naloxone is not addictive and it does not release dopamine. So by administering it, the overdose state is reversed and lives are saved. For people that abuse naloxone, withdrawal is often induced. Frequently referred to as dope sickness, withdrawal is manifested by pain, diaphoresis, hypertension, vomiting, and diarrhea. And while these symptoms are unpleasant for the person, the symptoms are temporary. Naloxone has no effect if administered. So if you or someone that was not on opioids, such as a child or even a dog, got into your naloxone, it would not affect them. Only if you have opioids in your system. So it's important for laypersons to have an understanding of how to respond to an opioid overdose. The steps needed to administer naloxone, regardless of the mechanism, are conducted in the same order. So the specific mechanisms will be discussed later for different administration routes. But step one is to check for responsiveness. So this is done, as I demonstrated earlier, by either shouting the person's name, pinching their earlobe, or performing a sternal rub. And if the person does not respond to these, or verbal or physical stimuli, then they may be in a state of overdose. So that's when you would want to check for breathing. So if you notice that they're not breathing, that's when we would want to initiate rescue breaths. So we would breathe for them 1 breath every 5 seconds. Calling 911 allows for EMS, fire, and police to arrive and provide additional services for the person experiencing an overdose. It's important to place them in the recovery position if you must leave them to call 911. And so we're going to show you a video on what that looks like.
Yeah, so like she said, this video will just show how to place that person in the recovery position.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position.
So I'd just like to point out, so in the picture we just showed you, they had 1 hand under the head, and in this video they have 2 hands under the head. It's okay to put them in either one of those positions as long as you get something under their head, like their hand, to elevate their head off the ground. So step 3, we're going to continue the rescue breathing. Step 4, we'll administer the naloxone, either depending on how it was prescribed or how you have it, it's going to be either intranasally or intermuscularly. And then after you've administered the naloxone, we'll resume the rescue breathing. This is one of the most important things to remember because it is, if the person is not breathing, brain damage can occur within 5 minutes if there's not enough oxygen to the brain. And then we'll conduct a follow-up. If the patient does not wake up within 3 to 5 minutes of administering the naloxone, we'll still continue the rescue breathing. And then if you have it, we'll give another dose of that naloxone.
So now we're going to discuss the available naloxone products, starting with the intranasal products. So as of right now, there are 2 options for the intranasal naloxone. One is FDA approved, called Narcan nasal spray, and that's shown in the bottom left. And this looks very familiar if you use any kind of allergy or decongestant nasal spray, and it's very simple to use. So complete depression of the plunger up one side of the nose provides the full dose. The other in the top right is a formulation that can be used either intramuscularly or intranasally in the hospital setting, and it's converted through the actuator, which is the triangular tip that you see there, into a nasal spray. And since we're unable to demonstrate the use of the Narcan nasal spray, we've got another video showing you how to use it.
Back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open the Narcan nasal spray. Remove and review the printed Quick Start Guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose.
The FDA-approved intranasal naloxone is available in 2 doses, 2 milligrams and 4 milligrams. So you would typically receive a box that contains 2 of the 4 milligram Narcan nasal sprays. And naloxone, as we stated earlier, is a temporary solution, and an emergency medical care should be sought out. So 1 spray into 1 nostril provides the full dose. And if administering more than 1 dose, then definitely use a new nasal spray. And rescue breathing may be helpful to continue oxygen flow to the brain.
Okay, so naloxone, as we said earlier, can also be administered intermuscularly. And so this means kind of like a shot into the upper arm or to the thigh. And both of these can be administered through clothing, and they both have their advantages and disadvantages. But today we're going to talk about the FZO auto-injector, and it's the FDA approved one, and it's again marketed under the name FZO. It comes in a box with 2 auto-injectors with 2 milligrams of naloxone each and a trainer. With the actual auto-injector, once it's used, you cannot be used again, and it should be disposed of in the trash. But actually, we found out as of a few months ago in late 2020, FZO is no longer in production. It is still approved for use as long as the product is available and not expired. So these may be more rare that you see them, but they're still good to know how to use. So we're still going to go over the steps. So for the auto-injector, you're going to pull it from its outer case, and we don't want to go to step 2 until we remove the red safety guard on the auto-injector. If you're not ready to use it, you can just put it back in the case. So once you've pulled off the red safety guard, we want to reduce the accidental chance of injecting yourself with it. So we don't want to touch the black base or at the bottom of it where the needle would come out. And so I would like to note that the red safety guard is made to fit tightly. So you're going to have to pull it very firmly to remove it. And we don't want to replace the red safety guard after it's been removed. So then the step 3, we'll place the black end against the middle or outer thigh through the clothing and pants, and it's necessary to push firmly and will hold in place for 5 seconds. If you do give the naloxone via an auto-injector to an infant less than 1 year old, you need to pinch the middle or outer thigh before you give the naloxone, and continue to pinch it while you administer the naloxone just to make sure there's enough depth for the needle to go through. We will show you a video on how to do this.
For this demonstration, we'll be using the FZO trainer. Notice its black and white color. Open the outer box and remove one of the 2 devices. The FZO product has voice prompts, which will activate as soon as you remove it from its outer cover.
Contains no needle or drug. If you are ready to use, pull off red safety guard. If not ready to use, replace the outer case. If you are ready to use, pull off red safe to inject. Place black end against outer thigh, then press firmly and hold in place for 5 seconds. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
So I would like to point out, you definitely, if you are using it and you have to use the FZO auto-injector, you will hear that click as you press in. And so make sure you do hear the clicks, and that way you know that you're giving the dose appropriately.
So naloxone should be stored in its original package at room temperature and out of direct sunlight. When dispensed, the expiration date for naloxone is typically 18 to 24 months. If you have a pre-filled syringe, you should not insert naloxone into the pre-filled syringe until ready to use. The non-FDA approved version for intranasal use, or the syringe for injection, because it'll expire in 2 weeks. And we suggest placing the expiration date on the front of the naloxone product in a Sharpie pen, and replace it before it expires. In case of an opioid overdose emergency, expired naloxone can and should be used. So expired naloxone will actually still work. It may just not be as effective as if it were in date, but definitely hang on to it. And we do recommend using it because it is better than no naloxone at all. So the average cash prices that a person would pay at a pharmacy are listed on the screen there. And some of these prices do look pretty unaffordable, but there are ways that we can obtain them more cheaply. So for example, the FDA approved naloxone nasal spray costs around $140 out of pocket. TennCare, as well as many commercial insurances, will actually cover the Narcan nasal spray, making it no cost to you. And then, as mentioned earlier, the Evzio will no longer be available for purchase. But this was the cash price when it was still on the market. So it was close to $4,000. But they actually had a website. If you went to the manufacturer website, they had a program that you could apply for, and almost everyone qualified for it. And you could get that auto injector for free.
So because Narcan is a potentially life-saving drug, we want to make it readily available to anybody, to as many people as possible. So in the state of Tennessee, there's a standing order that allows pharmacists to dispense Narcan without a prescription to people who have been trained, especially if you're with someone who's at risk of going into an overdose. And you can, additionally, you can receive the Narcan nasal spray for free through the Sullivan County Anti-Drug Coalition. And these are just some helpful resources that can be accessed through the internet, like the Tennessee Department of Health and the CPNP's Naloxone Access. It's a practical guide for pharmacists. And then there's also the prescribetoprevent.org. It provides access to other training materials and videos that were shown in this training. And do you guys have any questions?
Thank you, Madison and Veronica. That was a great training, and I think your videos were very powerful and helpful. Anyone have any questions about overdose prevention or naloxone use or any related topics?
Looks like Don has his hand raised.
Did you have a question, Don?
Okay, we've also got another question in the chat from Sandy that says, is Tennessee considering making Narcan free?
That is a good question. I do not know. I know I work at Walgreens, and I actually haven't seen a lot of people who pay for it, because if they have a valid need, their prescription or their insurance usually covers it for them. And then there's a lot of grant funding like what we do, and we can provide it through the Sullivan County Anti-Drug Coalition, provide the naloxone for free, but I'm not sure what it's going to do about it. I can definitely look into it and get back to you if you want to give me your contact information about it.
Could you talk a little bit more about the process? You know, say someone comes to Walgreens requesting naloxone. What's the process for determining need, and then kind of the details of the process for you know, them not to have to pay for it, for it to be covered by insurance, and how long does that take? Is there a role for like healthcare providers to play to make it easier?
Oh, definitely. So it would definitely probably speed up the process if a prescriber was to write a prescription for it and send it over like any other prescription. That way the pharmacy can go ahead and get it filled and get it ready for them. And then you just pick it up like an oral prescription. And if you use that pharmacy, then we'll go ahead and run it on your insurance, and it'll pop out either the copay or no charge, depending on how much the insurance wants to cover. But if you just come in and you have a medical need for it, because the chief medical officer of the Tennessee has the standing order for pharmacists to dispense the naloxone, we would look at your profile and see that you have a need, or maybe you can give us a specific patient that we might know is on a lot of pain medication or something like that. So then the pharmacist could not write the prescription, but put it in their profile like a prescription and run it through insurance that way to be able to dispense it. Since it is a standing order, it authorizes the pharmacist to go ahead and dispense it if they see a medical need from the person asking for it.
And have you seen like prior authorizations needed, or is it just as easy to pick up your naloxone as it is like your amoxicillin?
I wish it was that easy. I have definitely seen the prior authorization. Some insurances, it goes through just fine, no prior authorization, especially if the person is maybe has a prescription because they do have chronic pain. And so they regularly do pick up maybe an opioid. But for somebody who might be coming through because they're a relative or something, it might require prior authorization, which most people know can take a day or two. And that just, the pharmacists, at least I know a lot of pharmacists that are very active and will like call the insurance themselves to try to hurry along that prior authorization, but it might be something that you have to come back the next day to pick up the naloxone. But it is, at least at my Walgreens, normally stocked on the shelf and ready to be dispensed to anybody that comes in.
So there's
So
a
I saw, yeah, you want to ask the questions, Veronica? There's a couple in the chat.
Yeah, so we have one from Kara who says, as a pediatrician, are children able to be trained to help their parents if needed? And so I think certainly that would be a great idea, especially if their parents are substance users themselves and, the kids are the ones that are going to be around them most often. I think it's certainly a good idea for them to be trained. Now, I don't know how official that training would be, but I think knowledge is power. And I think that, the more that they know, the more that they are able to be there and can help. I am for it, certainly.
And so to kind of speak on that, next week, I know they're not kids, but we're going to Science Hill High School to give this presentation as well, just to kind of make them aware. And just because they're under 18, we can't give them the naloxone that we normally could. But I know a lot of times for the older kids, if they can get a waiver or like a kind of like permission, like parent permission, then we just kind of bear on the side of caution at handing a kid the naloxone because it is still a drug. But if the patient or if the parent is prescribed it and they have it on hand, that's kind of why we're going to Science Hill to do the training. So if they do see it in the house or at a friend's house, they know what to do with it.
Okay, and our next question is from Amanda, and it says, is there somewhere healthcare providers could sign up to have one in the clinic setting?
So definitely after this training, you can go to the Sullivan County Anti-Drug Coalition and they will happily give you the naloxone. We can also, I was talking to Dr. Melton and she said, because we're doing the training, we can get the numbers or the list of people from you guys and we can just dispense the naloxone to you all as well for this training.
That is a great offer, because I know if we were in person, you'd be able to do that. So certainly if there is someone who's interested in getting naloxone, you could either chat that in. You could send Katie Duval or I an email, or Madison or Veronica, if you all want to put in any contact information into the chat. We're happy to help facilitate though.
Yeah, definitely. I can throw my email in the chat. I was gonna say, if everybody was interested in receiving it today, we can just, if you guys have an attendance list for us, we can get that list from you guys and work on getting it distributed out to everyone. But I will throw my email in the chat really quick.
We definitely do have an attendance list since everybody registered. So.
And I can put mine in there as well too.
Oh, and I had a question. It says, if you're continuing to use this so the last value, so yeah, we have updated this as recently as we could. Some of the values developed by the Tennessee Department of Health are only from 2016. Some of them are a little newer. I'm not sure if they do it in like groups of time, but we updated this last semester and this was like the newest data that we could find was still a 2016. So I apologize about that.
It looks like we actually had someone in the chat, it says, "Hi all, I'm an epidemiologist at the Tennessee Department of Health, and I work with drug overdose data statewide. My office just did a soft release on our Tennessee annual overdose report that I wanted to share with you all. It contains updated information and rates as well as COVID effects that we have seen this far. Feel free to share with your network." So thank you so much. I really appreciate that.
Yeah,
Definitely
that's
interested
awesome.
to take a look at it.
Yeah,
And
please do. Sorry, this is Aaliyah. I have to jump off, but I wanted to quickly share that. Katie invited me to this, so I wanted to jump on and support ETSU. I'm an alumni, but yeah, definitely check out our new overdose report. It just came out, and I know some people were asking about COVID, and we touch up on COVID. And I mean, anything you want to know about any kind of drug overdose, we have gone through all of it. And this is an annual release too. So keep looking for it in future years, but this one just released. So definitely check it out.
awesome. Thank you so much, Aaliyah.
Yeah, thank you. We'll definitely do some updating.
I'm excited to look at it.
Yeah, thank you for that. And we can send that out through our listserv as well, because it sounds like that's hot off the press. And I know a lot of people would be interested.
Yes, we just did the soft release, but it eventually will be on the Tennessee.gov website. But for now, you can share it just via the link with anyone who it could benefit, definitely.
Oh, wonderful. Thank you. I appreciate
Thank you
it.
all. Thanks for inviting me. I have to go now, but it was a great presentation. Thank you all very much. And
Thanks
happy
for
to see
coming.
work. Thanks.
Thank you. So Madison and Veronica, I wondered if you had a sense of how we're doing in the region in terms of access to naloxone, and then, you know, if you could speak a little bit about barriers or things that, you know, those of us in the audience who are professionals or just, you know, residents, people, are there things that we could do as a community to improve?
Yeah, so I definitely think just with COVID, it's a little bit down. I do think the one slide we had in the 2017, 2018 about Washington County going down was really positive. And I would like to think it's because there is a huge outreach about it, but we do try to go to the RAM clinics, and there we can, we bring the naloxone with us. So as soon as we get people trained at the RAM clinics, we're handing it out before they can even walk away from us to make sure that there is good access to it. I'm not the involvement, like we're trying to get in with younger populations, like we're trying to get into with the high schools, and we do some youth presentations just to try to raise awareness early. But really, if anybody just wants to help, it would be like having people sign up for presentations when they see it, and then that gives us a chance to get them naloxone once they are adequately trained and stuff.
Is it stocked in schools in Tennessee? Is this something like, you know, an EpiPen that schools have or administer if needed?
So I know it. Oh, go ahead, Veronica.
So actually, yeah, I know within the past year or two, they've put them in the AED devices across campus. So a lot of our work has focused on like RAs and people around campus just to get them familiar with naloxone in case the need were to arise for them to use it. So yeah, they definitely are trying to get access to it on campus.
And you mentioned you're going to some high schools. Do you know if they, you know, have it available in case maybe a high school student or a staff or a visitor needs it? Do you know how?
Yeah, so this is actually our first year doing it with the high schools. So that was one of our goals, was to at least get it to the teachers and staff that we're going to train, because we're going to do some students as well, but to at least have some staff have it on hand so if something does happen. But that was something that Dr. Melton wanted us to touch with, is maybe talking about getting the process started of putting it in maybe their AEDs as well, since most teachers are CPR certified and would know how to access it if it is needed.
That's great. Thank you. Any other questions?
And can you hear me?
Yes.
Okay. This is Don Dale. I just had a question. For those of us who are non-medically qualified in a situation, I work with a community organization, CASA of Northeast Tennessee, And we often work with parents and some children who have an opioid problem. And to my understanding, there must be some medical qualification, even if you have naloxone on hand, in order to administer it. If you run across a situation where there might be an overdose, is it necessary, if you have naloxone on hand, is it necessary to contact someone medically in order to have that administered?
So actually, no, this was a layperson's training that we gave to you guys. So this, if you were here for the training, it makes you qualified to give it, because what we will be trying to get to you guys is the intranasal one that we showed in the video. So it's just as easy as giving like a allergy spray or something. So if you have it on you and you're not medically trained, but you've seen this presentation, we do ask that you would go ahead and give it to them if you feel comfortable, because you are protected with that Good Samaritan law.
Okay, thank you.
Mm-hmm.
And what we can do is get you the registration list if folks on the call are interested in that. We could share that with you, and that way they could get you the naloxone if anybody is interested.
Yeah, that's why we have it, so that we can train people and give it out. So if you guys want it, we'd be happy to give it to you.
Any other questions? So Caroline Ballinger said, I'm very interested in that. That's a great offer. So good, we can do that. Dr. Schaefer, she's one of our pediatric residents at ETSU. She's interested, and so is Sierra. So we'll get that list with you, and that way y'all can get in touch and get that out to folks. That would be wonderful.
Yeah, absolutely.
So Rachel wondered about a recording. So this will be posted on the ETSU Child and Family Health Institute website, the recording. And Katie might be able to tell us about how long that's been taking, because she is the person who gets that up, but it's pretty quick.
Everyone, so yes, I can probably have it up this afternoon or tomorrow morning, and I'll put the link to where we'll be able to find the video on our website in just a minute. Please feel free to share it with folks.
So good, lots of interest. I thought of one other question. So if I were to send a family to the clinic, or a patient to the clinic to the pharmacy to get naloxone, what does training look like for them in that situation? Is it something you all do in the pharmacy, or how do folks just coming to the pharmacy get trained?
So I'm not 100% about a lot of other stores, but Walgreens kind of asks that maybe you have a previous training, like something like this, and you can show that you've gone through the training. But it's really kind of like just, like, we also give out cards when we just give you guys the naloxone that you have been trained. So it just be kind of showing proof that you have had the training. I'm not sure if maybe some pharmacies do it differently, but I can only speak to Walgreens in our area. So I'm sorry. I can definitely ask around though, if you would, and get back to you on that.
Well, I was wondering, how people know where to get training, if that's something that's going to be required, or if it's even something that we could help, before we send someone to the pharmacy, is, how could we help them get that?
So we actually have the rapid training that we do at the RAM clinics. We have it a recorded one. So I can speak with Dr. Melton. I'm not sure how she would want to do this, but maybe giving you our recorded video, and if you can then facilitate people watching the video, it's about 10 minutes, and then maybe I'd have to double check with her, but having that count as their training, and then you could send somebody to the pharmacy after that with the naloxone.
Okay, that would be great. And I know that this is one of the new initiatives at ETSU Health, is to improve how we're connecting families to naloxone. So that would be wonderful if you could send that.
Yeah, I'll definitely talk to Dr. Melton. I'll email her when we're done today about that.
Okay. All right. Well, we are at the end of our time. Thank you so much, Madison and Veronica. You did a fantastic job. And I understand this is one of the first virtual online trainings that y'all have done personally. Is that right?
Yeah, so normally we like to do it in person. So this is kind of hard for us being away and not being able to demonstrate ourselves. And so lots of videos. I apologize.
Well, I appreciate you adapting to our format. So thank you so much. And
No
thanks
problem.
everybody for
Thanks
joining
for
us.
having us.
Yeah, thank you.
Have a great rest of the day.
Thanks.